Welcome, everyone, to the Socket podcast. Today, I am joined by Dr. Xavier Simcock of Midwest Orthopedic at Rush. Dr. Simcock reached out to me, I think in part because I run the Branch Moms community, and he'd seen our TV shows where we had people on and interviewed them about their specialties, their craft, the things that they love to do in their business life. So he and I connected and had a great conversation a couple of weeks back and thought it might be a great idea to bring him on the podcast to talk about what he does. And for our moms out there and our dads out there, how do you make decisions about certain injuries that your child may have or your teenagers may have? And how do you make that judgment call? Are we going to the hospital or are we waiting until tomorrow? Are we calling the doctor in the emergency line? And I know that a lot of you out there, as I listen to the conversations online, aren't always sure exactly what to do. Sometimes you ask on the branch and we just go, yeah, go to the hospital. But sometimes it's a tough call to make. Dr. Simcock, can you share just a little bit about your background and where you're at in life?
Well, thank you so much for having me on the Socket podcast. I'm thrilled to be here. I really appreciate the opportunity.
You're welcome.
So yeah, just a few minutes about me. I'm a transplant to Chicago area. I was previously on the East Coast for about a decade. My wife and I met in med school, and then as our training kind of progressed, we're kind of at different levels. But so when she finished her fellowship, she got a wonderful job here in Chicago area at Lurie, because she's a pediatric urology. And as they say, happy wife, happy life, right? So I made the smart decision to come with her. And so, yeah, so I'm an upper extremity surgeon associated with Midwest. And we live in River Forest. I have 2 kids. We have benefited from moms groups. Somehow dads aren't as sophisticated as moms groups. So my wife is a big fan of many different moms groups that she's been associated with. And so that was part of the reason why I reached out.
Yeah, it is so funny. We have a lot of our moms say, my husband wants to know where the dads group is in Naperville. Like, where can the dads get connected? And I've seen a couple pop up here and there, but they just haven't taken off quite like the moms. But
yeah, it's more like the softball league, right? And it's just not really as effective as a moms group. Yeah.
I don't know. Moms had to know how to get stuff done.
No argument.
It's an amazing thing to watch, especially our online mom forum community, just go all day long. Questions, answers, question, answers. Someone post a question about, someone fell off a swing set and I think they broke their arm. There's 47 answers in a half an hour. So, and now
that's a luxury. That's awesome.
Now I'll know that I can use you as a great resource. So,
sure.
How did you pick the arm? Like, I always think about, as a chiropractor, you go to chiropractic school knowing you're going to come out as a chiropractor. And then there's obvious specializations within that. I specialize in pediatrics and cranial work. But at what point in your doctor career, in your schooling, did you say, I really like the elbow, the shoulder, and the wrist and the hand?
Sure. Yeah, that's a great question. It's one of those things, it's amazing how much we study, and then it's only kind of by going through being an apprentice do we kind of figure that out, right? So in the later parts of med school, I got exposed to orthopedics, right? And so there's like a real luxury in orthopedics where the vast majority of time somebody comes in, they're like, hey, this hurts. We usually have some reason and or some sort of pathway to try and help that, right? And so that's wonderful, because a lot of parts of medicine I feel are tinkering, right? But this is an area where, like you get to be hands-on. We get to be kind of direct in terms of really approaching the problem, right? Which is just great. Orthopedics is a 5-year training, right? So you got a lot of years to figure it out. And what I realized for me was most of orthopedics focuses on the bone, and the bone is great, but it's not as interesting to me as the soft tissue. So the tendons, the muscles, the nerves, and it's this wealth of anatomy, and it's like a beautiful thing when you actually get to see it in the operating room. So to be able to put all those pieces together, that's what spoke to me.
Well, I like that. I remember going through school and having to do cadaver lab, and how unbelievably complicated these joints are and how that all comes together. It truly is remarkable as you study the body at a really deep level, and it's such awe of, man, all this comes together, like from 2 little cells, 2 little things,
Yeah.
So I
it's
think
amazing it all works, right? It's funny, we often think about it when it breaks down, but the reality is it works at one point, right? So it's just it's an amazing thing.
Yeah. And so what is the primary job that you have? Are you normally in the office seeing patients? Are you normally in surgery? Like, what's your percentage of when you're like office hours versus surgery hours?
Mhm. Yeah, so the reality, most people think of a surgeon as we're probably operating all the time, but we're not, right? I
Yeah.
only operate about a day and a half a week.
Okay.
And so, 4 days out of the week, I'm in the office. 2 of those days are directly in Naperville every week, right? So, yeah, we're more often than not in the office.
Okay. Okay. And so with what you do, what are the most common injuries you see? And are there many that you turn away? Like, not, this isn't severe enough for you to be in my office? Like, is there a judgment call there as well?
No, so I think many people feel nervous about because they want to feel validated. Look, I'm coming to the doctor. I don't want to feel blown off, and so they think, gosh, if this isn't like a bone sticking out of the skin, why am I here? But that's not the 99% of the time. That's not what we do, right? And it's for most people, there's an amazing peace of mind just knowing, hey, look, my architecture's okay. This is something that's going to get better, right? As long as we put some time in, we do some conservative therapy, maybe we brace, maybe we do some physical therapy, occupational therapy, maybe we need manipulations or what with chiropractic work.
Yeah.
But there's never anything where I just say, oh, look, there's no reason for you to be here. The only time that sometimes I maybe redirect patients is, hey, this is a muscular problem, say around your shoulder. And the honest answer is, I don't have good solutions for it. I don't have good solutions for it with cortisone. I don't have some good solutions for it in terms of surgery. Instead, you're much better off with chiropractic manipulations or McKenzie method or what,
Yeah.
so I will redirect people to other areas of specialty, but it's never like, oh, look, there's no reason for you to be here.
Well, and I think I appreciate that so much because, you see patients that have gone to different doctors in different specialties, and I do as well. And it's amazing how many people do feel blown off.
Yeah. Yeah.
Kind of like they didn't even barely looked at me. They didn't
Yeah.
touch my elbow.
Mhm.
I kind of felt like they were just like, no, that's not a surgical problem for me. So
Yeah.
we just need to get you out of our office as quickly as possible. And my practice works the same way. Every once in a
Mhm.
while, we're obviously very conservative care with
Mhm.
what we do, and we
Mhm.
do limited physical therapy and massage therapy as well. But sometimes people walk into our office and I'm like, nope, 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 hospital. Like, this is not a chiropractic problem, right? It's almost the opposite of, I need you to go get an MRI. I need you to go get a CAT scan or something like that. So we send those out as soon as we know that we're not the exact place they need to be.
What's interesting about that, I guess, is twofold. One is, you brought up validation, right? Oprah, when I was in Boston at the Harvard graduation, she gave the commencement speech, right? And this was kind of
Yeah.
controversial at the time because, sometimes they have such things as Nobel laureates and everything else, and people wondered whether she would be good or not, right? And the reality,
Right.
she was fabulous, probably the best one that they had in a decade. But one of the things she spoke to was just the importance of validation, right? And that, sure, even if you come in with a complaint like you mentioned, right, that people do feel blown off a lot because if it doesn't fit within a certain niche,
Yep.
then they may feel like, well, it's not mine, figure it out yourself. But that's not really our job, right? Our job is to be providers, and we're trying to kind of orient people as best we can.
Yep.
The other thing you highlighted is the ER. I can't tell you how many times that the ER will call me and then we just have them come quickly to the office because then we can give them a definitive plan, right? And that's one of the luxuries where we have X-rays and MRI on site and other things, and we can always call our friends at the surgery center if it really gets bad that we need to go kind of take care of things. So it's amazing how we can triage from here.
So that leads me to another one of my questions, so that I can get a little clarity on what you just said.
Sure.
Obviously, if your child falls off the swing set and there's a bone sticking out of the skin, we know this is an emergency.
Yeah.
Is that a direct ER visit? Is that where you're going with that?
Yeah, so the bone actually sticking out of the skin. So when we get worried about that, because to be honest, a lot of times people see a deformity and their mind takes them to a place where they really don't want to be, right? And if it's your kid, I tell you, right, there's nothing worse than seeing something that just doesn't look natural, right? If it's truly the bone or if there's blood at the area of the injury, the smartest thing is to go to the emergency department, because in that setting, we're worried about an open fracture. And if the bone from the inside touches the outside world, unfortunately, bone is very unforgiving in terms of infection, right? So if it gets infected, it likes to stay infected. And it's something we take incredibly seriously, to the point where we may bring them to the operating room that night or the next day or urgently. So if there's an injury and there's blood and there's a clear deformity and there's a lot of blood there and you're worried that the skin may be open, it's always best to be seen in the emergency department, hands down.
Okay.
If there's a little abrasion and other things, again, it's best to be seen. It may not be as an emergent thing, but if it's a big gash and there's blood and other things, and very few people are going to feel like, oh God, I can blow this off. That's
Right.
definitely a reason to go to the emergency department.
Okay. And that, like you said, is such a slim portion of what you see on a regular basis.
Correct. Yeah.
So let's say Johnny falls off the swing set, has an abrasion on his, forearm, and is in a lot of pain. Let's say doesn't feel like he can move it. One hard thing to see with kids is, it's hard to know exactly what they can or they can't do. Are they scared? Is it that much pain? It's hard to really judge that with some kids, right? So when you have like kind of that moderate injury that maybe something even is fractured in there and you don't really know, is the best thing just to go right away? Is it to let them get some sleep? I mean, I'm sure there's 14 shades of gray in there, I'm sure, but.
Yeah, I think there's 3 real pearls though to think about those things, right? And one is, it's easy to make snap judgments, being like, gosh, this is dramatic, right? I'm worried. And you're never wrong to be seen, right? It's an annoyance. The reality of going to an urgent care in an emergency department is that is going to suck up 6 hours of your time. And right, I don't know how good you are as a parent. To me, thinking about managing a kid that is in extremis for 6 hours is just bad for both of us, right? So it's a big commitment, right? I get that. And, yeah. I mean, it's just God. We're all in for a long night, right? There are 2 things that I think you can do immediately that can be really helpful, right? And one is distraction, right? And I think anybody who's been a parent knows that sometimes if you can get, the train going another direction, you can really focus on what is potentially the problem at hand, right?
Yep.
So if you give it a few minutes and you kind of get them to kind of focus somewhere else, let's say it's their arm, right? Because 80% of the upper extremity injury, or 80% of traumas in kids are actually involving their arm. And if you can get them to look away, sometimes they'll naturally just put it down on the ground and start pushing off on their arm, or they'll push off of the seat, or they'll do something like this. So distraction is a huge key in all of this. Okay, and time is a beautiful thing. Now, time can be worked against you, right? Because I have a funny story about that here in a second. But time, if you give it 24 hours, nobody's gonna blame you for saying, "Oh, look, I waited, I watched it for 24 hours, and then I was seen." Because a lot can happen in that 24 hours, right? So unless the bone is sticking out of the skin, sitting on it for a night, as long as the kid's comfortable and other things and it doesn't look grossly deformed, is completely reasonable.
Okay.
And then you'll get a better assessment the next day. Geez, is the pain just as bad as it was when it happened? And that's concerning that maybe something is fractured. Or, hey, look, this is really going in the right direction, right? We can watch this a little bit. Now, the funny story is I have a twin brother, right? And my mother was a general surgeon, right? So you'd think, she was always right. Of course, she was always right, but especially when it came to medical things. So my brother and I were skiing one day, and he had a big crash, and I had to get him down, to the bottom of the mountain, and his ankle was dramatically swollen. So my mother looked at it. She was like, look, this isn't a big deal. Okay. Gave him a few Advil. We got a pair of crutches. A week to 2 weeks later, he still couldn't put any weight on it. It was still bad, right? So then she takes him to the orthopod, and of course he had a fracture, right? And he managed to kind of just sleep it off with a couple Advil, right?
Yeah.
But it's still a funny story to tell at Christmas time today, right, with the family, right?
Remember when you didn't catch that fracture, Mom?
Yeah, well, she's the smart one. She was the doc. I was nowhere close to being a doc, so I couldn't get blamed at that point, right? So thank God for that. But yeah, I mean, not being able to put weight on it over time is a real red flag. So that's just a good thing to know.
Yep. Well, I broke my fibula 2 years ago in the summer. I was I had friends over. We have a pool, and we were playing football, and someone threw the football too far. I'm like, oh, I'll get it, and kind of got out, kind of jogged to get the football, and I just wasn't careful getting in the pool, and my left foot went in and slipped, and I came down on the stair on my right foot and then fell into the pool. And the first thing I thought is, oh God, this isn't good. But I did not think it was fractured. Sure. I really didn't. Because I'd sprained that ankle a couple of times. But then the next day I was like, oh, I can't put any weight on. I would try a little bit. And then the next day I was like, this isn't right. And and I almost displaced the fibula enough to need surgery. My surgeon was like, I actually sent your x-ray with your permission to 4 other doctors to make sure that they are in agreement that we can do this conservatively.
Right.
So it's hard to tell sometimes.
It's really hard. It's always great to get another set of eyes on the problem too, because then, you feel better about coming to a consensus.
Yeah, for sure. So, okay. So in the upper extremity, what are the top 3 injuries that you see?
So in kids, right, or adolescents, right, falling on an outstretched wrist happens all the time. And in kids, like, the monkey bars or the playground, the most common is the fracture around the elbow, right?
Okay.
And so, we call it a supracondylar fracture. There's no test at the end, so you don't need to remember that. But it always happens from they let go, right, because they're holding on for too long, and they land on the arm outstretched. And the elbow is the classic place to just kind of give way, right? Yeah. And that's one where if they're still having pain with moving the elbow in a day or two, right, and it's really hurting them, it's always safest to just get an x-ray, because the vast majority of those, people always get scared that they may need surgery and everything. The vast majority we can manage conservatively, and it may just be a cast for 2 weeks or whatnot.
Okay.
But that's the most common at the playground, right? As we get a little bit older with kids, falling on an outstretched arm, either from the bike or, from rollerblades or whatever, distal radius fractures or both bone fractures, right, which is both of the 2 bones in the forearm, the radius and the ulna. Kids, they have this luxury that they're growing, right, and they grow from the growth plates, and it's an amazing thing they can. But they actually grow from the growth plates, which is cartilage, which is a weak point in the bone. So sometimes that acts as a place where it displaces, and so we need to kind of line that back up so the growth happens in an appropriate way. But so for kids, it's really the distal radius, the forearm bones, or the elbow are the most common things we see.
Okay. And like you said, not every one of those goes into right into surgery, right? I mean, it depends on the displacement of the bone and things like that. Most of them are casted, braced, things like that. Okay.
Yeah, so the way we kind of manage that is, conservatively, is it a stable fracture? I mean, things are lined up and the bone isn't likely to move. And in that case, we can just put it into a brace. So then, you can still swim, you can take a shower without the cast bag and all those things. If it's a fracture where we're worried, like your fibula fracture, where it's possible it will move, then sometimes we have to be conservative up front and put it into a cast for a couple weeks, and then we can start working towards, your motion.
Yeah. So I get a little claustrophobic.
Sure.
And so I had a cast put on to begin with. And at 4:00 in the morning, I called Edward Hospital in Plainfield. I said, if I get an Uber, it was my right leg, of course, so I couldn't drive. And I was home by myself. My kids were at my ex-husband's. Like, if I get an Uber to the hospital, will you cut my cast off? Sure. The woman was like, do you mean the cast that your doctor put on? No, we don't do that. Man, it did give me a little sensation of claustrophobia in a weird way. I don't know if that's something that's common.
It happens all the time. And the reality of that is, I work with a lot of occupational therapists who make kind of custom made, plastic braces for people, so that whenever it's safe, because, being in cast jail is not fun, right? If we can get you out of cast jail and get you into a brace, then at least you could have a moment where you can take it off and be like, oh, I'm free. Yeah. And then when you get over that moment, you can go back in, right? And so we can manage that. Yeah, but it's way more common than you think.
So I feel a little more comfortable telling you that I then called my doctor, who's a friend of mine, and said, I need you to cut this off, and I need you to put me in a boot. And I know that you don't agree with that, but I don't know that I can handle this. And so I had this great boot, and it was, and she was like, if we do this, you can't put any, no, nothing. You're literally taking a risk. I will accept where you're at. And I was diligent. I did not put that foot down for a half a second. But it was so nice just to be able to let it breathe every once in a while. And
especially in the summer, right? A sweaty wrist or a sweaty foot.
Oh, it was July. It was July. So, and my toes were just peeking out. Yeah. I think if I do it again and I have to stay in a cast, I'm gonna have to do some sort of hypnosis or something. I'm like, I don't know. I don't know what I'm gonna have to do. I'm a pretty strong person, but man, you have that feeling of non-movement, and I don't know. It doesn't work for me.
It's worth bringing up quickly. Not that surgery is always a good option, but honestly, it's always a conversation you have with people, because sometimes it's better to fix it, right? And then it's like, you don't have to be in a cast, you don't have to be in a brace, you can weight bear on it, right?
Yeah.
And it's all about quality of life things. So it's a possibility. So it's a reasonable conversation to have. It just, you always have to tailor the right answer to the person. So
For sure. For sure. What are your biggest kind of sports injuries or overuse injuries that you see?
sure. So, for adults, really, a lot of people like to be active, and I like to keep them active. And I would tell you that at the shoulder, the common thing is either rotator cuff tendonitis or a frozen shoulder, right? And the reality of those is they both feel the same to the patient, right? But the treatment is different, right? So rotator cuffs, a lot of times with therapy and moving things along in a kind of more progressive way, you can make a lot of progress quickly, right?
Yeah.
And so that's like overuse in terms of overhead activities or maybe weightlifting or whatever people like to do. A frozen no problem. A frozen shoulder is totally different, right? A frozen shoulder is way more insidious. It kind of creeps along and kind of really knits the shoulder together, such that all of a sudden somebody has dramatic pain just reaching behind them in the back of their car or trying to put their coat on.
Yep.
And this is where it's important to tease out the differences, because what happens is if you push people too fast in that, it's a game of just creating the fire all over again, right? And in doing that, then you're just in this death spiral of pain where you're never going to make progress. As opposed to if you're really diligent, and oftentimes I even just coach patients myself on the therapeutic exercises so that they don't get pushed in an uncomfortable way, to just do stretches, slowly that'll give way. And as that gives way, you'll see a dramatic improvement, and then you can get back to doing the things you want to do. So for the shoulder, those are the two most common.
Okay. Well, and I know for many of my patients, and I'm sure you see this too, they just want it to be better now, and sometimes it's like, this is just a process. It's, I wish I could magically wave my magic arm over you and, no pun intended, my magic arm, but, and make your shoulder magically feel better immediately. And sometimes it really does. Maybe sometimes it's very fast, but sometimes it just is going to take time. And that's hard.
And it's so hard. I think what's hard there especially is like, oh, hey, look, my neighbor had shoulder pain and it was better in 6 weeks, right? And they had this. Why isn't it better for me, right?
Yeah, right.
And that's where the key in diagnosis and actually understanding what's going on is crucial, right? Because it's really important just to normalize what is your path. And then if you can kind of get comfortable with that, then I think we all buy in.
For sure. Well, I had a very severe cooking injury. I wish my fiance is like, you need a better story than this. I'm assuming that it is coming from years and years and years of adjusting. I picked up, excuse me, I picked up a really heavy pan with my left arm. I twisted it to try to put the leftovers into and I almost dropped the pan on the counter and felt like a knife went into my elbow. And then it kind of went away. I mean, I was just like, oh my gosh, what the heck did I do? And then I'm super smart. So a half an hour later, I pick up the same pan with the same arm and make the same movement to put this huge pan into the sink. And I dropped it in the sink. And I was like, wow. I iced my elbow. I didn't think it was that big of a deal. I went in the office the next week. I probably adjusted 60 patients. And with every patient, it got worse and worse and worse to the point I couldn't pick up a glass of water. So told my office manager I was going to take 2 weeks off. 2 weeks later, it's not any better. And I'm icing it and finally got an MRI and I had a partial tear of the extensor tendon. It was a year ago. Now, I am a terrible patient. I don't know if you're a good patient when you hurt yourself. For those of you that are just listening, he's making kind of a shaking his head movement of no, he's not.
I don't know any medical professional that is a good patient. So
so of course I'm still adjusting patients, even though I've limited my scope quite a bit. And I ice it and I did some physical therapy for a while and it's better, but I don't think it was ever any type of surgical. I don't know. Maybe I'll have you look at my MRI.
Yeah, well, so you bring up classic tennis elbow, right? And so tennis elbow is the scourge of the elbow, right? And it's one of those things. I see it, 3 or 4 times a day, at least in the office, and I operate on it like maybe once a year. And it's one of those things that the problem for us is we are grabbing with our hands all day, every day, right? So You think you get a break, at night you're even grabbing because we all kind of go into a little bit of a fetal position and we're putting tension on it. So the backside of your arm is not getting a break then. It's not getting a break with any time you're lifting something. So a glass of water still aches it. Manipulations, you're always grabbing, right? So of course you're using your grip strength there. And the problem is all of our fingers, all of our wrist extensors, all that power and grip that we get out of our hand all starts in one spot, and it's on the outside of our elbow. And it's the
I know, I feel it right now.
Yeah, right there. Yeah.
Right
if
there.
we talk about it more, you're going to get a bag of ice on it. So we better be quick. The reality of it is tendons get poor blood flow. So we would all be better off if you broke a bone at that elbow because it would heal faster, right?
Yep.
And the natural history of tennis elbow is it's maybe 1 in 1,000 people that has it that actually plays tennis. And it takes 2 years potentially to burn out. Right? And nobody wants to hear that, right? That's just a reality.
No.
But over 90% of people, it will burn out. So everything I do with patients is to try and make that time course a little bit faster and then to try and get smart, right? How do you work with your hands so that you're not aggravating?
Yeah.
And the ultimate key is to try and convince people to act like a 3-year-old, right? A 3-year-old will lift everything with 2 hands, and one's kind of underneath it and one's to stabilize, right?
Yeah.
And so what you want to do is you want to try and do all of your activities by looking at the palm of your hand. If you're looking at the palm of your hand, you're not using those muscles. You're using the muscles on the inside of your elbow.
Yeah.
And if you're looking at the back of your hand, you're using those muscles on the outside of the elbow, so they're not getting a break. And if you buy into that, which just sounds crazy, right? Because who wants to act like a 3-year-old all day? You will finally get some relief because you're finally not throwing wood on the fire, right?
It's so funny because I didn't know to say that, okay, this way doesn't hurt, that way does hurt. But I'm always amazed that there's some things I do that just doesn't aggravate it at all. I mean, and I understand the mechanics of that, right? You're just not engaging that area, but and then I go to do something and it's like, oh no, like we're not doing that at all.
And that oh no is either extending the wrist, right? Or it's making a power grip, right? And so when you're talking about the pan, you were making a power grip with the pan and then basically lengthening the muscles by putting the pan down in, and that's what really set it off. What's interesting is if you take all people that come into the office for an elbow complaint, and it's not tennis elbow, it's not the lateral side, it's something else, and you get an MRI, over 50% of people are going to have some tearing in their common extensors.
Gotcha.
So it's everywhere, right? And reality is the MRI doesn't actually change the treatment, right? Even if you have a partial tear. If you have a full tear, it's a different conversation, but it's just there in all of us, and it's going to hurt you sometimes and not others. And so it's just something we learn to work around.
Well, that's not what I wanted to hear.
Well, it'll go away. You're a year in, you're already halfway there, and maybe faster.
I know. It's been interesting. It's funny. When I did that, we had just gone into a pandemic. Our practice was closed for 5 or 6 weeks, and then we opened back up. And then I did that within like a week or two, and then I started Socket. It was like, well, I'm home. Like I couldn't adjust for probably 6 more weeks. So I just felt like the universe was telling me, stay home and go do something else. And so, I get bored easy. So I might as well come up with something different.
It's just a good excuse to use your mind on another task, right?
For sure. So what would you say are some of your primary proactive, let's keep the arm and the upper extremity healthy advices, whether that's pillows, sleeping positions, ergonomics, that's something within those categories?
Sure. So I guess I'll take that in two veins, right? One is, let's talk about injuries first. Let's say you have a little something that happens, right?
Yep.
And so it can happen in your hand, it can happen in your fingers, you could stub something, it can happen in your elbow or your shoulder. Counterintuitively, the body will say, look, I'm in pain. And as an intuitive person will just say, hey, look, I'm going to wait this out. If I wait this out, it's going to get better. And that's true. It may get better, but in the upper extremity, especially, you're going to get stiff. Okay. There's no doubt about it. Right. And so no matter what the injury, assuming it's not something dramatic, right, there's a benefit in within a day or two, starting to work on just gentle motion. If that's just pumping the fist, right, and bringing the fingers all the way in, if it's doing little circles with the wrist, if it's, even if you have a major injury around the elbow, if you're just gently kind of moving the elbow back and forth or turning it upside, over and back. So looking at the palm and then looking at the back of your hand, all of that is safe, right? Gentle motion, unless it's a major injury, is usually safe. So
Okay.
what I find for a lot of people is some people are like, look, hey, I've waited for 6 weeks for this to get better. I thought it was good. I even bought myself a splint. And now we're looking at a stiff finger, right?
Mhm.
And that's just we're just adding months to the recovery, right? So gentle motion, gently working through pain and those things with an early injury is a wonderful thing. Okay. In terms of life ergonomics, and I think, I was even actually surprisingly on the news for this, that we all went to a home workplace, right? And what we didn't realize was at work, even though we may not have agreed with the furniture choice or the design or these sort of things, the ergonomics at workplaces have actually been thought out more than you think, right?
Sure.
And so when we all went home or we were like, maybe we like to work on the couch, or, we've kind of created a mini Starbucks in our house, whatever it is, we're usually not in a position where we're actually designed to work in. Okay. And so a couple tricks there, all of us have worked on laptops or tablets or something in the last year, right?
For sure.
And what we've done in that is we're trying to kind of work in a small space. But normally what we're doing with that is we're usually kind of cramped up. We've either cramped up our shoulders, we've cramped up our elbows so they're flexed to 90 degrees, and we're working kind of directly in front of us, right, on the laptop. The safest thing to do to prevent kind of injury in terms of nerves or compression neuropathy and those sorts of things is actually to work at a table, right, and push the laptop away from us. Try and have your elbows, almost fully extended, something comfortable like 30 degrees, because as soon as you get them past 50 degrees, you're actually putting more pressure on the ulnar nerve. And then people often think, oh gosh, I've heard about computer typing, I've heard about these other things, that all causes carpal tunnel. What's amazing is it doesn't, right? There's actually really good data that it doesn't. But if you're feeling it, if say you've had it for other reasons, if you're working in a position that's cramped again, and you've either got your wrist cocked back or cocked forward, you're going to find yourself exacerbating those symptoms and making that pain worse. So even if you're working on a laptop, there's still value in getting one of those little gel pads or making sure your wrists are straight, right?
Yep.
And nobody has to see you with the gel pad, right? You're not trying to win any competitions, but it does keep your wrist in a neutral position, and that really does help you.
I am so old enough that I just don't care if anyone sees me with a gel wrist pad at this point, I have one of those track balls that literally is like your finger uses it. It's just a ball. And my staff thinks that I'm crazy. I'm like, I don't know if I do too much with the full wrist with that. And I've gotten so used to just using my first finger for my pointer finger for it. And I love it. I think it's great. So
the other thing that's valuable there, actually, not only, so the tracking mouse, right, with the finger is awesome, but also there are vertical mouses that you can just use with your thumb. So if you find like you're getting irritation in your tendons or your extensor tendons, tennis elbow, to go over to a vertical mouse to get a break or to switch it up, right, is a wonderful thing too.
Yeah. Yep. Well, there's so many little tweaks. I mean, we go through this at our office as well, especially with sleeping positions, right? People are like, oh, I sleep on my stomach. And I'm like, well, let me show you my spine. And I bring my spine over and I put the spine face down, and then I turn the skull. And man, you see rotation all the way down the spine to the lumbar area. And I was like, unfortunately, if you're sleeping in this position and your head's turned, because you can't breathe face down, right? You're not sleeping in a massage table, even though that'd probably be pretty comfortable. That you're torquing the entire spine, the entire nervous system. So that's a good visual. But it's amazing to me how many little shifts, I'll have people take a picture of their work desk, or send me a picture of how you work. And then sometimes people are funny and they're all like, on the couch, all gimped up together, like, because everyone's working, like you said, working from home, and they don't normally have that workstation set up. So I always recommend, like, take some time, even if your company won't invest in it.
Sure.
Invest yourself. If you're going to be here for a year, you might as well just make yourself as comfortable as possible. So you're then not setting yourself up for injury that now you're going to have to come see me or come see you or come see someone else, go see someone else.
It's amazing if you're proactive, you can really, kind of stave off a lot of these irritations.
For sure. For sure. Well, Dr. Simcock, this has been such a great conversation. I really appreciate you coming on and sharing your wisdom. And I now know more about the management and treatment of the upper extremity, which I appreciate.
Well, it's been wonderful to be here. You're obviously very good at this, so it's been a very easy conversation. So thank you so much.
Oh, well, thank you. It was funny because normally we're talking about, more like emotional intelligence and confidence, and the Socket podcast is a little more geared towards women. You're actually my first male interview, so so thank you for braving the world. And what is funny is that one of my girlfriends thought I named the podcast Socket because I was a chiropractor and because it was joints. So
Oh,
and it's actually plug into you, like plugging into yourself, plugging into your gut, listening to yourself, things like that. But I figured we could bring you on and I just pretend it was because of joints and that we'd talk about the arm joints.
well, I'm just going to think about it as only the joints, so I love it.
Well, thank you so much. I hope you have a great rest of your day.
You too.
And if anyone would like to reach you or your practice manager, someone wants to come and see you, what's the best way to get a hold of you?
Yeah, well, the easiest way is just to give us a call, right? Because
Okay.
Tina is my assistant, and I am very blessed to have her, and she's an amazing person to contact. So yeah, our office number is 630-339-2240. And then, I'm online and other things. There's a lot of different ways to find us. So any way you want to reach
Okay.
out, we're happy.
Well, I know I'll be reaching out to you to get some information so I can have it in my office because we certainly have people that, some we can manage in-house and some we need to refer out. So always great to have more resources under our belt.
Well, I'm very privileged to be part of the team. So thank you so much.
You're welcome. Have a great day, everyone.